You are listening to the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat.
Hi everyone, and welcome to the December 2017 special Masters edition of the PRS Journal Club podcast, focusing on craniofacial surgery. My name is Jordan Frey, PRS Resident Ambassador from NYU, and as always, I'm joined by my co-resident ambassadors, Shuja Shafqat from Fox Chase Cancer Center and Chad Purnell from Northwestern. So today we have the honor of being joined by Dr. Jeff Fearon, Director of the Craniofacial Center in Dallas, and an Associate Editor of Plastic and Reconstructive Surgery Journal. Thank you very much, Dr. Fearon, for joining us for this special Masters of Plastic Surgery edition of the PRS Journal Club podcast.
Thank you for your invitation.
The article we'll be discussing next is entitled 5-Year Follow-Up of Midface Distraction in Growing Children with Syndromic Craniosynostosis. This is from Drs. Patel, Shetye, Warren, Grayson, and McCarthy from NYU. And as a reminder to everyone, all of this month's articles can be read for free on prsjournal.com, and that includes an archive of all past Journal Club articles. So in way of an introduction, the authors discuss that in syndromic patients with midface hypoplasia and/or exorbitism, advancement of the midface improves the exorbitism, the nasomaxillary and zygomatic hypoplasia, anterior crossbite, as well as any airway pathology associated. And the Lefort 3 operation addresses all of these parameters. However, distraction osteogenesis of the midface after Lefort 3 using a rigid external device or RED device offers advantages of a shorter operative time, decreased blood loss, and increased advancement and stability compared to immediate advancement with fixation and bone grafting. And there are some early results that have been reported at 1 year suggesting that the maxillary segment after this procedure is stable in the x-axis while continuing to descend in the y-axis, but long-term outcomes are lacking. So the author sought to look at their long-term outcomes, with this being a retrospective chart review of all patients who underwent Lefort 3 distraction osteogenesis with the RED device from 2000 to 2007. And in their methods, they described their operative technique for Lefort 3 and placement of this device, and they mentioned that their clinical endpoints for midface advancement were determined by clinical evaluation of the craniofacial bony and soft tissue profile and cephalometric evaluation. And they mentioned the growing child, the midface was overcorrected until a point of about 4 millimeters of positive overjet, as they anticipated a lack of horizontal growth in these syndromic patients, and that in order to avoid an ophthalmos postoperatively, they advanced the midface and stopped when the inferior orbital rim was at the level of the anterior cornea. They then described the results. They had 17 consecutive patients that met inclusion criteria, 10 male, 7 female, 7 with Cruzon syndrome, 5 with APART, and 5 with Pfeiffer. The average age at time of primary Lefort 3 distraction was 5.7 years, but ranged from about 3 to about 11 years. They weren't specifically looking at complications, but they noted that they had no late complications, defined as greater than 1 year postoperatively. Getting into some of the data they present after device removal, they noted specifically that the orbitale advanced about 14 centimeters along the x-axis and downward about 14 millimeters. The A-point advanced about 16 millimeters along the x-axis and downward about 1 millimeter in the y-axis. And then at 1 year post-distraction, which was the next time point, both the orbitale and A-point had advanced an additional about 0.5 millimeter and 0.3 millimeter in the x-axis and downward 0.6 and 1.8 along the y-axis. And then their last time point was at 5 years post-distraction, noting that the orbitale moved posterior while the A-point advanced along the x-axis, and then the orbitale and A-point both descended along the y-axis at that time point. And notably, there were no significant differences in skeletal movement between patients with different syndromes at any time point. In their discussion, they mentioned that, again, the traditional Lefort 3 osteotomy and advancement procedure has been shown to improve exorbitism through expansion of the orbital volume, improving symptoms of obstructive sleep apnea through expansion of the retropharyngeal space, and improving maxillary and mandibular disharmony. And while previous studies show that secondary advancement operations at skeletal maturity may be required with this technique, it's due usually not so much to relapse, but rather minimal horizontal maxillary growth and normal mandibular growth. And distraction osteogenesis of the midface has distinct advantages over traditional Lefort 3, however, with early 1 year results previously showing stability in the horizontal dimension. And this cohort kind of piggybacks on this information, as this cohort at 5 years of follow-up demonstrated that midface distraction can be performed in the growing child without evidence of inhibition of future growth. And according to cephalometric data, there was no evidence of relapse at 5-year follow-up, although there are some soft tissue changes and remodeling that they anecdotally note in their patients that may occur, leading to a clinical picture of relapse, despite it not being evident on cephalometric analysis. And they also noted, lastly, that the need for secondary advancement is judged subjectively and was not necessarily assessed in this study. So I think overall it was an interesting and important study. Obviously, distraction osteogenesis was something largely developed by Dr. McCarthy, who is a senior author on this paper. So it's interesting to see the long-term follow-up on these complex patients undergoing these challenging procedures. And ultimately, the study, I think, demonstrates the stability of the midfacial segment after Lefort 3 with distraction osteogenesis in the RED device, as well as what appears to be continued midfacial growth at 5 years of follow-up. But it's also important to note that relapse, at least with regards to cephalometric analysis, was not necessarily evident, but there was some clinical evidence, and they attribute that to the soft tissue changes. So that's something that would be kind of interesting to look at more. But like with any good study, a lot of new questions arise. So I'm interested, Dr. Fearon, to hear your take on the study and any opinions.
It's another great study out of NYU where they've been really careful to follow their patients over a long term and document the kind of changes that they're seeing. And it offers, I think, great corroborating evidence to prior studies that have looked at this. Same thing, the maxillary stability following Lefort 3s, and have shown that your advancement more or less remains stable after doing the operation.
Yeah, my question, beyond some of the technical aspects that I'm sure we'll get in a little bit, with these patients, how should outcomes or success in these cases be assessed or defined? Is it the clinical picture? Is it the cephalometric data? Is it how happy the patients are when they're older? How happy the parents are right away? What do you think about that? And, how should we be assessing success?
That's a great question, Jordan. This operation is done for really two reasons: to improve ventilation and to help normalize appearance. So I think our outcome measures have to be twofold. One is polysomnography data. It's important to look at this because there's a clear relationship between the position of the maxilla and then the degree of impaired ventilation. And so if the purpose is to normalize ventilation, that's something we need to follow. We found in our own patients in Dallas that there is a tendency for sleep studies to worsen over time, especially if you're doing the operation earlier. So number one outcome has to be looking at polysomnography data. And the second needs to be kind of a patient or family reported outcomes in terms of how they feel their appearance is. And one kind of way of looking at that is tracking the need for subsequent procedures that these children get after they've hit skeletal maturity.
I think those are great points. Shuja, what did you think of this article?
I agree. I thought this was a really interesting paper, and it was good to see that the use of distraction osteogenesis, clearly while having numerous advantages, stays stable over time, and the authors did a good job of showing that. I too found it interesting that while patients, can show clinical signs of relapse but may not show cephalometric signs, which shows us that sometimes we have to look at our outcome assessments subjectively and objectively to really determine what our success rate is. And I agree with what Dr. Fearon said. I think it's, we have to assess our outcomes based on the defined goals of our surgery. I think sometimes we can get lost in looking at little details that weren't in our initial plan or weren't the initial goals of surgery. I personally wondered how having Apert, Cruzon's, and Pfeiffer's syndromes, while similar, but having all three different patients kind of lumped together, if those patients can truly be compared to one another. But again, another study where it's difficult to get a large number of patients. But Dr. Fearon, you mentioned about patients requiring additional procedures. So I was wondering, in your experience, do you find that most patients with these dysostosis syndromes require redistraction after they've already been distracted once, or do you find that the distraction kind of holds up over time and they don't need that redistraction again?
That's a complicated question, Shuja, because it depends on a lot of variables. The decision as to whether or not you're going to need to do a second operation is, first of all, it's going to be based on, does the child develop recurrent sleep apnea or do they not look normal? One of the interesting things this study showed, which again corroborates other previously published studies, is when you do this operation, you stop forward maxillary growth. So no matter what age you're doing this operation, and NYU, they're doing it at an average age of 5. Dallas, we do it at average age 9. But whenever you're doing it, at that point, you're stopping forward growth. And so if you're stopping forward growth and there's additional growth left, you need to overcorrect. So the determination of how often you have to repeat this is going to be based on when you do the operation and how much you overcorrect, those two variables. My former fellow Neil Patel looked at 32 of our patients that had gotten to skeletal maturity. And in that series of kids that had been just treated with halo distraction, 25% of them either received or found to need secondary Le Fort 3s. And we found that what correlated with that need were the degree of severity initially, which we have no control over, but not surprisingly, the age. So the earlier you did it, the more likely you were to need to redo it. And the second thing was how much you overcorrected. So based on that study, I've now been overcorrecting more, and subsequent to that, I have not been repeating Le Fort 3s in these kids. So I think the answer to the question is if you can wait to age 8 or 9 and you can overcorrect sufficiently, you'll never have to repeat the operation.
Great, thanks. Those are excellent points. Chad, what did you think of this article?
This is a really important article. And I think not just this article, but also this idea that in craniofacial surgery, we really need to follow these patients for a significant amount of time, because we're often operating on pediatric patients and you've always got that fourth dimension. I'm not saying it's easy to do a Le Fort 3, but it's easy to do a surgery and walk away, but we're actually affecting these children's growth for the rest of their life. And so we really need to be mindful of our results, and we need to report our results, I think, in order to really optimize our endpoints for these types of procedures. So kind of in that vein, Dr. Fearon, I wanted to ask you, and I wanted to kind of get a little bit more into the technical aspects of doing Le Fort 3 distraction. You talked about overcorrecting. And so I just wanted to know, whenever you're performing a Le Fort 3 distraction, what are you using as your clinical endpoint, and how do you know how much to overcorrect? So here they were using some positive overjet, or that the orbital rim was level with the cornea. What do you use whenever you're distracting a patient? I know you said you do it around age 8 or 9. What do you use as your endpoint, and how do you know how much to overcorrect?
Again, that's a tough question to give a good answer to because it's going to depend on so many factors. But the critical thing to remember is the maxilla is small in 3 dimensions. So not only is it back, but it's vertically short and it's narrow. And so when I'm setting my vector for distraction, I think the 2 things I'm looking at is 1, untelescoping the nose, and the second is positioning the malar eminences. Because to get vertical lengthening, we're going to really rely on the Le Fort 1 if necessary, and to get widening, we're going to use palatal expansion. So I look to overcorrect at the malar eminence, and that's going to also be age-dependent overcorrection. And the way I learned how far to overcorrect was a patient that occurred early in my series. Most of my patients do not live in Dallas. Over 90% don't. But this family lived in the Dallas-Fort Worth area, and I wanted to see him back every week. And the family did not return to my office until they had gotten to the end of the screws. So they just kept distracting and kept going without an endpoint except as limited by the device. And so when the child finally walked into my office, I thought, my God, I've helped contribute to this caricature. And I was thinking, I don't know how I'm going to set the maxilla back. So I said to them, let me just kind of follow and see how you do. And I followed him over time. This occurred when he was 9. And by the time he was 17, he was in a perfect relationship. And so looking at how far he had been overcorrected at age 9 helped give me an idea that I think you need to position the malar eminences well in front of the anterior surface of the cornea if your goal is to not repeat this operation. And for me, that's the biggest goal because, these operations probably have the second highest complication rate of anything we do in craniofacial surgery, secondary to mandibular distraction. But Unlike mandibular distraction, which tends to have smaller, more minor complications, these are pretty significant complications. So no family wants to repeat this operation. I think that if the family is willing to balance having the child appear overcorrected for a year or two, it can avoid the need for a real major procedure down the line. So that's basically my endpoint.
Great, thanks a lot. I think those are some great technical points. It's obviously a very complicated question, but I really appreciate the answer. And Jordan, we'll kick it back to you.
Oh, I think that was a great discussion. Yeah, I enjoyed that little anecdote about the patient overcorrected. I guess, chance sometimes breeds discovery. I think with that, we'll end our discussion of this article. So remember, everyone, tune in to the other 2 articles that we're discussing on this month's podcast, as well as all of our previous and future podcasts that we're broadcasting every month. And don't forget to participate in our monthly hashtag PRS Journal Club on Twitter, where we'll be able to interact directly with this month's selected articles' authors. And as we've been saying, I just want to say a special thanks to all of our listeners, as well as everyone at PRS, as this is our last Journal Club podcast with Shuja, Chad, and myself, as next month we'll be handing over the reins to next year's ambassadors, Francesco Agro, Ira Savetsky, and Nikki Phillips, and I know they're going to do an incredible job. And once again, especially thank you very much, Dr. Fearon, for joining us for this Masters podcast.
Thank you, Jordan.